In trauma care, some decisions have to be made in a split second, and the consequences, well, they can last a lifetime. Today, we are diving deep into one of the most critical calls a doctor has to make: clearing the cervical spine.
Okay, picture this. You're in the ER. It's loud, it's chaotic, a trauma patient has just been wheeled in, and the clock is ticking. In the middle of all that, one of the very first things you have to figure out is the neck.
We're talking about the cervical spine, or C-spine. A missed injury here? It's catastrophic. It could mean paralysis or worse. Now, in trauma patients overall, the rate of these injuries is about 3.7%. But here's the kicker. In an unconscious patient, that number more than doubles to 8%. That's a huge jump, and it really highlights the problem when your patient can't just tell you, hey, my neck hurts.
So you're walking this incredibly fine line. On one side, you have the risk of missing an injury that could change someone's life forever. But on the other side, if you immobilize someone unnecessarily for too long, you can cause a whole other set of problems. So, today, we're going to walk through the modern, evidence-based way clinicians thread that needle.
To really get a handle on where we are now, we first need to understand how much our thinking on this has changed. We've moved from a pretty rigid, better safe than sorry playbook to something way more nuanced and, frankly, a lot smarter. The single biggest change? It's this move away from slapping a rigid backboard and a hard collar on basically every single trauma patient. We've swapped that out for a much more thoughtful approach called spinal motion restriction, or SMR for short.
SMR isn't about just strapping everyone down anymore. It's about being selective. Why? Because we now know that lying on a hard plastic board for hours can cause incredibly painful pressure sores. And a collar that doesn't fit right can actually make it harder to breathe or even dangerously increase the pressure inside the skull. So this isn't just about comfort, it's about actively preventing harm.
And this new way of thinking about the spine is really part of a much bigger shift in how we prioritize things in a trauma bay. The old rules have been rewritten to reflect a very simple, very stark reality. You have to treat what's going to kill the patient first.
Everyone knows the classic ABC: airway, breathing, circulation. Well, it's gotten a major upgrade. Now it's XABCDE. And that little X at the front, it's a total game changer. It stands for exsanguination. We're talking massive, life-threatening bleeding. And it is at the top of that list for a very, very good reason.
Here's the bottom line, and it's brutally simple. You can't save a patient's spine if they've already bled to death. Nothing in trauma kills faster than a massive hemorrhage. So you stop the bleeding first. Then you make sure they have an airway. Protecting the spine is absolutely critical, but it has to be done in the right order. The priorities are now crystal clear.
Okay, so once those immediate life and death threats are under control, we get to the absolute heart of the matter. We arrive at the one question that determines everything that happens next for the C-spine.
The answer to this one question, is the patient awake, alert, and examinable, is the pivot point. It's a fork in the road that splits the entire process into two completely different paths. One path relies on clinical judgment, and the other relies on advanced technology.
So what do we mean by examinable? Well, it's someone who is alert, they're not intoxicated, and they're not so distracted by, say, a really painful broken leg that they can't even tell if their neck hurts. An unexaminable patient is the opposite. They might have a head injury, be under the influence, or maybe they're intubated. They simply can't participate in an exam, so we have to go a different route. Let's follow both paths, starting with the patient who can actually talk to us.
For the awake patient, we basically get to be clinical detectives. The whole goal here is to use our examination skills to safely clear their C-spine without having to expose them to the radiation of a CT scan if we can avoid it.
And to do this, clinicians have two incredibly powerful, well-proven tools. These are clinical decision rules, and they're so good that they can rule out a significant C-spine injury with over 99% accuracy. Think about that for a second. That level of certainty lets us confidently say no imaging needed for a whole lot of patients.
Now what's really interesting is how these two rules work. Mexis is kind of the quick and easy one. It's simple to remember, but it has some absolute deal breakers. Any tenderness right on the spine or any sign of intoxication and boom, they have to get a scan. The Canadian C-spine rule is a bit more complex, but it's also more sophisticated. It actually considers how the injury happened and can even clear some people who have a little bit of tenderness. It's just a more nuanced tool.
Let's just walk through the Canadian C-spine rule real quick, because it's a brilliant piece of clinical logic. First, you look for any high-risk red flags. Is the patient over 65? Was it a dangerous mechanism, like a big fall? If the answer is yes, they go straight to imaging, no questions asked.
If no, you move to step 2 and look for low-risk factors. Was it a simple rear-end collision? Can the patient walk around? If they meet any of those, you can go to the final step, asking them to carefully try to rotate their neck. If they can turn their head 45 degrees left and right, the C-spine is cleared. No radiation, no extra costs. Just good, solid clinical medicine.
All right, let's switch gears completely and tackle that other path, the patient who can't help us with an exam. This is where the detective work stops and we let the technology take over.
For the patient who is unconscious or just can't be reliably examined, the rule is dead simple. You cannot use those clinical rules. It's not an option. The physical exam is useless, so the decision is already made for you. You go straight to imaging. There is zero shortcuts here.
And when we say imaging, the choice is unbelievably clear. You know, a big analysis showed that traditional X-rays miss almost half of all C-spine injuries. That's basically a coin toss. No way! A modern, high-resolution CT scan, on the other hand, it catches nearly all of them, with a sensitivity around 98%. That is the difference between peeking through a keyhole and seeing the entire room. CT is the gold standard for a reason.
And this right here is the absolute take-home message, especially for those unconscious patients. It comes from every major trauma guideline out there. If a modern, high-quality CT scan shows zero injury, it is safe to clear the C-spine and take the collar off, period. Even if the patient is still unconscious, the odds of that CT scan missing something unstable are practically zero. And that is a huge deal because it means we can get patients out of those uncomfortable collars way sooner.
So we've walked down these two very different paths, one guided by our clinical skills, the other by amazing technology, and we've seen how they both get us to a clear answer. So let's just boil this all down to the key things every clinician needs to have locked in.
Look, clearing the C-spine today is all about a few core ideas. First, priorities. You use the XABCDE approach to treat what kills first. Second, you have to be smart. You use those validated clinical rules to safely skip the radiation in low-risk patients who are awake. And third, you have to be decisive. You use the incredible power of a CT scan when your patient just can't be examined. It's a system that perfectly balances risk, evidence, and technology.
But what about that tricky situation where an awake patient has a totally normal CT scan, but their neck still really hurts? It's a super common problem. The approach here is careful. It's step by step. For mild pain, that collar can probably come off. For more moderate pain, maybe they go home with a soft collar for comfort. An MRI is really only saved for the most severe cases, or if a new neurological issue pops up. It's another great example of a tailored, patient-specific plan.
And all this leaves us with a really fascinating question about the future, right? I mean, we've gone from immobilizing everybody to using these smart clinical rules to relying on powerful scans for the highest risk people. As CT technology keeps getting faster and safer and cheaper, will we eventually get to a point where those clinical rules just become obsolete? Will the future of clearing a C-spine just be a quick, low-dose scan for every single trauma patient? It's a question that really gets to the heart of how we balance our own clinical judgment with the raw power of technology in medicine.